Before beginning the physical examination, the examiner first introduces themselves, clarifies their role, confirms the patient's identity, and explains the intended examination using patient-appropriate language. The examiner gains consent, offering to provide a chaperone if appropriate, and washes their hands. For a detailed description of how to prepare for a physical examination, refer to the course Preparation for Physical Examination. To perform an examination of the nose, the patient is positioned on a chair in such a manner that the examiner has good access to the nose and, if necessary, nasendoscopy can be performed. Exposure is from the neck up, removing any hats, scarves or high-collared sweaters. A general assessment of the patient is first made, in order to gauge their overall level of health, and physiological parameters should be checked if this information is available. A focused general examination is then performed. Starting at the hands, the examiner looks for peripheral signs suggesting smoking, features of chronic infection, malignancy or bleeding, and looks for any other systemic or general features that might suggest nasal pathology or involvement, such as telangiectasia in the context of nasal bleeding, or scarring from a cleft lip repair. For a detailed description of the various components of a general examination, refer to the course General Examination and Vital Signs. Inspection of the nose is performed with the examiner sitting in front of the patient with the knees together, at either side of the patient's knees. The patient is asked to look forward, keeping their head in a neutral position. The nose is inspected from 3 different viewpoints: anteriorly, laterally, and inferiorly. The nose can be divided anatomically into thirds: an upper bony third and a lower cartilaginous 2/3. Inspection should note the symmetry of the nose, the presence of bony deformity or septal deviation, and any overlying skin abnormalities or rashes. From the sides, the profile of the nose, including the presence of a dorsal hump, saddling, or ptosis of the nasal tip can be observed. From below, the symmetry of the nares or narrowing of the external nasal valves can be looked for, in addition to more subtle deviation of the septum, and the presence of scars, such as scarring of the columella, suggesting previous open rhinoplasty. A full aesthetic assessment of the nose is beyond the scope of this course. The nasal bones and nasal cartilage are next palpated to assess the nose for symmetry, any swelling or areas of tenderness, and any palpable step-off or fractures. The nasal tip can be palpated to assess elasticity and to assess the support of the nose. If indicated, palpation over the paranasal sinuses can also be performed. The frontal sinuses are palpated by placing 2 fingers underneath the eyebrow. The anterior wall of the maxillary sinuses can be palpated by applying pressure over either side of the maxilla. Percussion over the paranasal sinuses can also be performed, looking for tenderness or a difference in percussion note between both sides. Note that this is rarely performed in clinical practice, with nasendoscopy, CT and MRI scanning forming the basis for investigation of suspected sinus disease. To perform an internal examination of the nose, a nasal speculum and a light source are used. In this film, the examiner wears a headlamp and uses a stainless steel nasal speculum. Holding the speculum between the thumb and the 4th finger, the closed speculum is inserted through the external nair into the left nasal vestibule, placing the index finger of the examining hand against the external nose to allow control. The speculum is carefully opened while pushing it slightly laterally, taking care not to press the speculum against the nasal septum medially. The external nasal valve is inspected. The nasal mucosa is inspected for the presence of bleeding, masses, ulceration, exudates, and polyps. The nasal septum can be examined for dislocation or deviation, septal perforation, and any identifiable areas of bleeding. At the anterior-inferior part of the septum lies an area known as Little's area, containing Kieselbach's plexus, a vascular network of 5 arteries that supply the nasal septum. This is the most common origin of anterior epistaxis. Anterior rhinoscopy is performed bilaterally, comparing the 2 sides. The inferior nasal cavity is visualized to be able to inspect the inferior turbinates, noting any asymmetry, inflammation, or polyps. The speculum is removed from the nasal passage with the blades of the speculum slightly but not completely closed. Complete closure of the speculum whilst inside the nose risks trapping a hair between the tongues of the speculum, which can be painful for the patient. Nasal airflow is commonly assessed by the examiner occluding one nostril at a time with their thumb and asking the patient to breathe normally through their nose. This is performed bilaterally, and any difference in airflow is noted. Cottle's maneuver can be performed by placing lateral traction on the cheek in order to open the nasal valve. If the patient reports improved breathing on this side, this is suggestive of a narrowing at the level of the ipsilateral nasal valve. If not, the site of obstruction is more likely to be further inside the nasal cavity. To complete an examination of the nose, a full ENT assessment should be performed, including, if possible, flexible nasendoscopy. The lymph nodes of the head and neck should also be palpated. For a detailed description of this, refer to the course Examination of the Neck. If a lesion of the postnasal space is suspected, a full cranial nerve examination should also be performed. After completion of the examination, the patient is thanked and the examiner again washes their hands.